be on this stage to speak about dental implants in younger patients. But first of all, what do we mean for young patients in dental implantology? There are the growing patients in whom the facial growth cannot be considered stable, and there are the so-called younger patients in whom the facial growth has been completed, and in literature they can include patients aged up to 40, 45. And we know that vertical growth slows significantly around the age of 20, but in some specific case of 25. So implant placement should be delayed until the skeletal growth is completed. Otherwise, we can observe these results with migration of the implant as an ankylous tooth. So to perform implantology, we need two superimposed cephalometric films taken 1 year apart, showing no change. But if we want to propose a dental implant rehabilitation to a 21 years old patient, like in this case, one of the first questions is durability. And durability is very important both for clinician and the patient. And we know that the implant survival rate at 10 years is more or less 93%, but with ankylous system we have the same survival rate, but there are low rates of peri-implant bone loss, and this is very important. And the prosthetic ankylous components, being very narrow, are excellent to restore patients affected by agenesis of the lateral incisor, like in this case. In this case we used standard Bartman and gold copings with a little drop of cement. This was an initial econometric concept, and these are the results we can achieve using commercial denture teeth for immediate loading and metal ceramic crowns as definitive restorations. But this is an old case. Today, if I had to discuss the treatment with this patient, being younger patients informed about new technology, and we can discuss about the quality of this information, as Van told us, I'd use the Simplant software to show to the patient and to the patient parents how we can analyze the bone volume and how we can plan the correct implant diameter and length and position, avoiding risks for the natural teeth. And our results allow us to be optimistic in proposing dental implants in younger patients. We can perform a subcrestal implant positioning, maintaining stable peri-implant bone levels, or we can maintain peri-implant bone levels, stable peri-implant bone levels, even if we perform a crestal implant placement, like in this case, at 3 years follow-up, 5 years follow-up, 7 years follow-up. Look at the bone surrounding the implant shoulders. This is a topic of the ankylous system. And younger patients have high expectations in terms of aesthetics. For post-extractive single-tooth implants, the socket shield technique, has been recently proposed, but we can have up to 20% of complications. But with the ankylous system, we can obtain great results without the socket shield technique, like in this case, a tooth resorption, with a bone resorption tool, and Talmor said, no buccal plate, no implant. And Dr. Renato Benato, my mentor, performed a careful extraction, implant positioning with a good primary stability. We placed an angled standard abutment. We tapped a gold coping for immediate provisionalization, and we filled the gap with a bone substitute. And this was the final result. And after 3 months, tissues were very stable. So Dr. Renato Benato relined the provisional crown, and soft tissues went down. And this is amazing. This is really amazing. A definitive metal-free ceramic restoration was cemented onto the foreign scissors. And look at the buccal plate regeneration, stable at 3 months follow-up, 3 years follow-up. And the soft tissue stability over time at 6 years follow-up. And we published this approach. But we can realize an immediate screw-retained restoration too, like in this case a coronal fracture, again with the standard abutment, a gold coping, and a little screw on the top. And we will always obtain good soft tissue stability. Why? Because we have a little amount of titanium and a lot of space for tissues. And this is the chamber concept of Marco De Gidi. This is the key for success. And if we have no bone, no basal bone, we have to give a chance to our younger patients to keep their trust. Otherwise, they can ask a second opinion. Autologous bone graft could be safer using a guided bone harvesting, as we publish it. And we can analyze the defect, we can discuss it with the patient through a virtual planning, showing to the patient how we can fabricate a guide to safely harvest the bone, preserving the nerve, reducing the patient anxiety. And on the day of surgery, we harvest the bone using the guide, and with the surgery, we manage it using the curious technique. We scrape the autologous bone particles from the cortical lamina, and we fix the cortical lamina with the bone particles inside using fixation screws. And thanks to the guide, the intraoperative time was reduced, so we placed implants in the posterior regions too, the same day. And curious technique gives a predictable healing, and after 4 months we placed 2 ankylous implants and in the new bone, and after another 4 months a metal ceramic restoration was cemented onto the abutments. Another important key point: a prosthetic drive and implant planning is very important for durability of our treatment, and durability is very important for our younger patients. So we can use a computer-guided implant planning to show to a young patient, like in this case a 26-year-old patient, a post-traumatic case, how we can plan our implants with the correct emergency profile thanks to the scanning of the diagnostic workup, preserving the sinus. And this patient asked me why the other implant placed in another center was so close to the sinus. And we gained the patient confidence from this reason. And on the day we ordered the guide, and we placed the implant as we planned, with a very predictable way. Younger patients are afraid about dental treatments and pain, but computer-guided implantology seems to be less painful with respect to conventional implant therapy. And Dr. Benato and I combined computer-guided implantology and intraoral welding, developing a guided weld approach for immediate loading cases, shortening the treatment time. And we published it first. And this approach allows to better plan econometric retention or a screw retention, or the combination of these two. And what do we do? In this case of a 40-year-old patient with a terminal dentition, we fabricated a 2-part radiographic guide because of the presence of teeth to be extracted on the day of surgery. We perform a dual scan protocol, virtual extractions, implant positioning, abutment selection. We designed the titanium bar into the software using the nerve tool, mimicking a perfect passive contact between the copings and the bar, and the bar has to remain inside our prosthetic spaces. But we can check it in the cross sections. And we ordered the guide. We pre-model the titanium bar on the model cast as previously designed into the software. We fabricated a prosthetic shell. And on the day of surgery, after extractions, we perform a guided implant placement. These were the final insertion torque values we registered. We tapped the econometric copings, the old econometric copings, we screwed the cylinders, and after little adjustments, the copings and the bar were welded together. Just in some seconds. And this was the final shape of the bar superimposed to the pre-shaped one. Look at the predictability of this approach, and we aligned a very thin prosthesis without artificial gingiva, and this was the final result. And soft tissue stability over time, this is the ankylosing system. And we improved recently our digital workflow thanks to optical scanning technology and thanks to our dental technician, Stefano Momik. We scanned the copings, and importing the copings into the software allows to better plan the correct bar position, also in restricted prosthetic spaces, like in this case in lower incisors. And on the day of surgery we have all set up so the intraoperative time is reduced for the patient happiness with a flapless approach, and our framework will stay always inside our prosthetic spaces. And this is not a young patient, but she would like to be, and this could be an expectation of some patient, but I briefly present this case to show the results we can achieve with this approach, using this approach in complex cases. Thanks to CAD softwares, we can design our new teeth, our new occlusion. We can use this 3D information to plan implants, to plan our framework with econometric retention. And again, on the day of surgery, we have all set up and we can perform extractions, guided implant placement, intraoral welding, in the upper and in the lower jaw on the same day, all these steps with great predictability. And after trimming and opaquing our frameworks, we can realign our prosthesis with econometric retention, and we will always obtain good soft tissues results. And this patient was so happy to look younger. And the econometric retention allowed to simply remove just in some seconds our prosthesis to check our implants. So in conclusion, some take-home message. Younger patients have high expectations in terms of aesthetics, with respect to aesthetics. And ankylosing system and the chamber concept allow predictable and stable results also in the aesthetic regions. And we have to use the new technologies to communicate better with our younger patients and their parents, to keep their trust and to plan shorter time treatments in order to reduce patient anxiety and fear. And I thank you for your kind attention.